Okay, so lumbar puncture. Lumbar puncture is nothing but a procedure in which we put a syringe or a needle into this lumbar vertebra to remove the CSF fluid. Okay, so coming to the definition. Lumbar puncture or spinal tap is the removal of spinal fluid by inserting needle into the lumbar subarachnoid space. Okay, so sometimes lumbar puncture is also known as by the name spinal tap. So the doctors they use to say spinal tap or lumbar puncture (LP) most of the time. So it is removal of the spinal fluid, that is your CSF fluid, by inserting needles into the lumbar subarachnoid spaces. So now indication, coming to the indication of spinal tap. So to make diagnosis for any CNS infection like meningitis, encephalitis, or CNS syphilis, okay, in case of any subarachnoid hepatitis, to make a diagnosis of this, we do the spinal tap. And then evaluation and diagnosis of demyelinating or inflammatory CNS processes like your multiple sclerosis or Guillain-Barré syndrome, GPS, okay. So these are the diagnosis. Or even we do this spinal tap in case we have to infuse any anesthetic agent or any chemotherapy drugs or any contrast agent into the spinal cord. Okay, and even for the treatment of idiopathic intracranial hypertension, so we do this spinal tap or LP. So now coming to the contraindication, to whom we should not do this lumbar punctures or spinal tap. So in case if the patient have this increased intracranial pressures in case of cerebral herniations, okay, when your brain tissues are swelled and then your brain tissue moves away from their original places. So in case of this cerebral herniation or impending herniation, we cannot go for this procedure LP. And in case if the patient have any coagulopathy like IDC, okay, in case if the patient have any coagulation disorder, then we cannot go for this uh, spinal tap. Or if the patient have any prior lumbar surgery, or if the patient have any severe degenerative disc disease, or if the patient have any infection near the puncture site, then we have to avoid doing this lumbar puncture or spinal tap. So in case if the patient have increased intracranial pressure, the sign and symptoms may be changes in LOC, that is loss of consciousness. In eyes, you will see papilledema, papillary changes or impaired eye movement. And in posturing, you will see decorticate, okay, flaccid, and the motor function will be decreased. There will be headache, there will be seizure, and in vital signs, there will be altered respiration pattern. The systolic blood pressure will be increased, your pulse will be decreases, and there will be vomiting, changes in speech. All right, so these are the signs that the patient have increased intracranial pressure. So now this is a picture of your lumbar vertebra or your spinal, okay, cord. So now you have to do this procedure. Okay, we have to do this. The placement of the needle will be in between this L3 and L4, or in between L4 and L5. Okay, we can use either two spaces. The first space will be either in the between this L3 and L4. The second space will be between this L4 and L5. All right. So now where to insert the needle, okay? So now we have discussed about the definition, the indication, the contraindication, all right? So now where do we have to place the needle? The imaginary line that crosses the lumbar regions of the back join the posterior iliac crest. So I think all of you have known this iliac crest, okay? The palpable, so when you palpate your hips, you will find some crest, the bone, that is your iliac crest, okay? This will cross the L3 and L4, okay, interspace, all right? So when you feel in the iliac crest, they should cross the imaginary line. They should cross this iliac crest, and then it should cross again the L3 and L4 space. All right. So now, when you insert the needle, okay, there are many things that you have to purse. Okay, the first thing you will purse skin, and then it will go onto your subcutaneous tissue. It will go on to your supraspinal ligament, and then it will go to the interspinal ligament, ligamentum flavum, dura mater. After dura mater, the syringe will burst to the arachnoid matters and finally into the subarachnoid space. Once your needle is in subarachnoid space, you have to draw your CSF. All right. So these are the tissue that is being purged. That is in the order. Okay. First, your skin, subcut tissues, supraspinal ligament, interspinal ligament, ligamentum flavum, dura matters, the arachnoid matters, and again your subarachnoid matters. Okay. Finally. So now coming to the equipment, okay, nowadays we have, when we go to abroad, you will see this LP kit. It used to come in all together with this LP kit, okay, your drab, your syringe, your bile, and then even your local anesthetic, they used to come in those kit, okay. or if in right now in this present scenario we have this LP needle where we have to track all this the lidocaine and then vials and even your draft separately. Now let's see the LP kit. Okay, so there will be 3 cleaning sponges. Okay, one before, one after the procedure, one during the procedure, all right. And then there will be a 20 gauge spinal needle. Okay, it may be either 25 or it may be either 20. Okay, 3 syringes. Okay, and then a vial of lidocaine for anesthesia. Okay, 1% lidocaine for anesthesia. It should be without without epinephrine, without adrenaline. Okay, a pressure manometer keeping in case if you want to check the pressure of the CSF, then we could have a manometer with tubing. Okay, for collection vials. Okay, uh, for this LP needle LP procedure, we always need 4 vial. Okay, most of the time we use 3, but one we keep it any for any viral markers or any other special case. Okay, and then the banded to close the area. So the other tools you required are your sterile gloves, gowns, povidone cleaning solution. Okay, as this is a sterile procedure, we need a sterile gloves, gown, povidone iodine cleaning solution. All right. So now, okay, a spinal or a lumbar puncture tray should include a sterile dressing tray, a sterile gloves. There should be a drape. Okay, a whole towel or a fenestrated one. The antiseptic solution with skin swabs, lidocaine 1% without epinephrine, a syringe 3 ml, needles with the LP needle with either 20 or 25 gauze. Okay, and then a 3-way stopcock in case if you want have to connect this manometer. Again, the manometers for plastic tubes. Okay, now it should be numbered 1, 2, and 3, and 4 with the caps, and in syringes that is 10 ml is optional. Now coming to the patient preparation. Okay, so local anesthesia is employed for lumbar puncture. Okay, because this is it will give a lot of pain to the patient, so we always have to employ local anesthesia, 1% local anesthesia without adrenaline. Okay, the patient is placed in lateral recumbent position. Okay, we can place the position either in this lateral decubitus position and either in a sitting up position. All right, so the first choice of option for this LP position is your lateral decubitus position. Okay, with the hips, knees, and chin flex. Okay, with the patient hips, knees, and chin, it should be flexed. Okay, in the lateral side, this position is known as the lateral decubitus. Okay, towards the chest. Okay, so as to open the interlaminar spaces or interspinous distance. Okay, why do we have to flex these knees, hips, and chin? Okay, just to increase the interspinous distance. Okay, the spinous, if we have increased interspinous space, then it will be easy for the needle to go through to your subarachnoid space. All right, so below may be used to support the head. All right, so now coming to the lateral decubitus position. Okay, any topical anesthesia, okay, it should be given before half an hour prior to the procedure. And then spinal cords, it used to L and L1 and L2. Okay, your spinal cord, remember this point, this is important. Your spinal cords ends at L1 and L2. Okay, so the site of the puncture should be below your L1 and L2, especially it can be go through between L3 and L4 or L4 and L5. All right, because your spinal cord ends at L1 and L2. If you punctured below this, you are all right. L3, L4, or L4, L5. But if you punctured up on the above of this, your spinal cord will be injured. So you will have so many complications. All right. So you should puncture after your spinal cord. That is after your L1 and L2. All right. So restrain the patient in lateral decubitus position. Okay, you have to flex maximally without compromising airway. Okay, while putting the patient in lateral decubitus, you should not compromise your airway also. The knees should be flexed. Okay, the hip should be flexed, and with your feet. Okay, keep the alignment of the feet, knees, and hip all together. Position head to left if right-handed or vice versa. All right, position the head to left if right-handed or vice versa. All right, so this is a lateral decubitus position. This is the first choice of option for spinal tap or lumbar puncture. So coming to the sitting up position. All right, the patient has to sit up. Okay, take the support from your for a cardiac table. All right, so even the placement should be in the between this L3 L4 or in between this L4 and L5. Okay, so lateral decubitus position is the first choice. Okay, it is more safer and we can measure CSF pressure from this. But in case of the sitting position, this is the second choice. Okay, there is a higher risk of herniation, and we cannot measure CSF pressure from this sitting position. The location will be in between L3 and L4, or L4 and L5. All right. So the punctured off area should be below L2, because in place of this L1 and L2, your spinal cords end. All right. So now coming to the procedure. Okay, now so till now so far we have learned about what is spinal tap, the definition of spinal tap or lumbar puncture, the indication, the contraindications, what are the equipment required. Okay, and then what are the position that we maintain, that is your lateral decubitus position and your sitting up position. So we prefer this lateral decubitus position. All right, so now coming to the procedure. So now we have to cleanse the skin with povidone iodine from puncture site radially out to 10 centimeters and allow to dry. Okay, so we have to clean the part, okay, with the povidone iodine, and it should be spread out till 10 centimeters and allow them to dry. Now the second thing will be draft the patient. Okay, draft the patient, and then around the side with fenestrated drape. Okay, your whole towel. Anesthetize the area with lidocaine. Okay, if topical is not used, then we have to use with 1% lidocaine without adrenaline. So intradermally raising a wheel at needle incisor site. Okay, while giving this anesthesia lidocaine, we can raise a wheel at a needle insertion site. Okay, and then advance the needle through the wheel to the desired interspace. Okay, so you should be very careful not to inject into a blood vessel, okay, or to the spinal canal. Okay, so insert the spinal needle with a stylet, okay, with the bevel up. Your bevel should always be facing upward. Okay, so you should be facing to the roof. Okay, so while inserting the spinal needle, the stylet, okay, the bevel should be up to give the cutting edge parallel with nerve and ligament fibers. All right, now hold the needle very firmly. This is how you insert, okay, with the bevel up. Now a popped up sudden decrease in resistance. Now when you insert the needles with the bevel up, now you will feel a little. My voice is audible to all of you, right?
Yes, ma'am.
Now, when you insert the needle with the bevel up, okay, you will feel a sudden decrease in resistance, which indicate that you have punctured ligamentum flavum and dura. So now we have to remove the stylet and check for the flow of spinal. Now, as soon as you remove the stylet, as soon as your needle is in subarachnoid space, when you remove the stylet, now you will feel the flow of the CSF. Okay, a clear fluid will come. Then it's confirmed that now it is in your subarachnoid space. Now, if there is no fluid, if there is no fluid, then we have to rotate the needle 90 degree, okay, and then reinsert the stylet and advance the needle slowly, checking frequently for CSF. Okay. Okay, so rotate the needle in case if you do not find, if the fluid are not coming, and again if you rotate the needle, after rotating the needle, reinsert the stylet and advance the needle a little slowly. Okay, but you have to check for the frequently whether the CSF are coming or not. So even your jugular vein compression can increase CSF pressure in flow situation. You might have seen this situation, okay, where the doctors, when they do not find, when they do not when the fluid doesn't come when they insert, when you do this procedure, they used to do this jugular vein compression. They used to compress this neck vein. Okay, so the purpose for this jugular vein compression is it will increase your CSF pressure in low flow situation. If bony resistance is felt immediately, then you are not in the spinal interspace. Okay, if you felt the bony resistance, then you are not in your spinal interspace. If bony resistance is felt very deeply, then we have to withdraw immediately to the skin and redirect, okay, and increase the patient flexion. Okay, redirect for more cephalate and increase your patient flexion. Now reposition the patient, and now increase your flexions of your head, of your knees and your hips. Okay, and then you have to restart the procedure. If bloody fluid that doesn't clear or clot result, then we have to withdraw the needles or re-attempt at a different interspace. All right. Now the steps of procedure are: first we have to clean, okay, prepare the position, okay, the either in the lateral decubitus or in the sitting up positions, okay, the knees, the hip, and then the chin should be flexed properly. And then after the position, you can clean that area. Any problem? Ivan Nilang Bina, do you have any problem? Please unmute yourself. I mean, mute yourself. Okay, so now we have to position the patient, okay, in either lateral decubitus or in the sitting up position, but the first choice is your lateral decubitus position. And after this, we have to get ready with our equipment and then clean the area with povidone iron solution, okay, which spread at least 10 centimeter, allow them to dry, and then insert the needle, okay, with the bevel up facing the roof, okay. And then after this, you will feel a little resistance, so it is make sure then with this it's indicate that your needle is in the interspace, okay. Now you remove the stylus, you will see some fluid that is confirmed that your syringe is in your subarachnoid space, okay. If you don't find any fluid, then you have to rotate the needle 90-degree, okay. Then you have to reinsert the stylus, advance the needle, but you have to frequently check whether the CSF is coming or not. Even you can do with this jugular vein compression to increase the CSF pressure. And then if you felt any bony resistance, we have to pull out the syringe immediately, okay. And then we have to reposition the patient and re-attempt it again. All right. Now this is the steps of procedure. Now in case if you want to check any pressure, okay, so we have to connect manometry, okay. When the CSF flows, we have to attach these manometers to obtain the opening pressure if desired, okay. So pressure can be accurately measured in lateral decubitus positions, okay, in the relaxed patient. So now for this, we have to attach the three-way stopcock when the free flow of CSF is obtained. And now read the column, okay, when the highest level is achieved, okay. So now this is just our plan, okay. Now we have to position the patient, mark the side, the landmark of the LP, and then we have to mark the side of the LP, and then it will be, we have to set up way, and then we have to prep and then wrap the patients, and then next we'll go for this local anesthesia 1% lidocaine without adrenaline. And then in case if you want to go for deep anesthesia, we can. And then we'll go with the procedure that is lumbar puncture, okay. And then after this, if you want to check the opening pressure, then we have to attach this three-way stopcock, attach the manometers, and obtain the pressure, okay. And after this, we have to collect the fluid, okay, the CSF in a 4 container that is marked as 1, 2, 3, and 4, and then we have to finish up the procedure. Now check closing pressure with the manometers, okay, in a now check the closing pressure with the manometers if desired. All right, so all the opening pressures and the closing pressure can be monitored if we required. Reinsert the stylet and remove needle in one quick motion. All right, so we have to reinsert the stylet, okay. After reinserting the stylet, we have to remove the needle in one quick motion, okay. There should not be any delay, and do not remove the needle without inserting the stylet, okay. Reinsert the stylet at one you have taken out, and then remove the needle in just one quick motion. All right, and we have to cleanse back and cover the puncture site, okay. We should do a compressive dressing over the side puncture site. And now this is the some of the pressure that we do, okay. The opening pressure, it will be around 130 to 180 when the patient is laying in lateral lateral position. And then the appearance and colors of the CSF will be colorless, okay, will be very clear. The blood cell count and differential count will be of the white blood cell, the red blood cell, okay. And then the glucose will be around 2.8 to 4.8 millimole per liter. Total protein, bacteria, we can either go for this gram stain cultural VDRL, it should be negative, okay. The pH normal for this of CSF is 7.28 to 7.32, okay. And then we can go for this lactate dehydrogenate, lactate chloride, okay, any cancerous cell, and then glutamine, cryptococcal, and these are the things that we can go for a CSF analysis. All right. So now complication of lumbar puncture. Okay, now the procedure is being done. So what are the complication of a lumbar puncture? By the way, did you understand the procedure, the steps of procedure? Now the equipment, we don't need anything. Okay, we just need some sterile dressing tray. We need LP a kit or a LP needle. Okay, we need a sterile gloves, gown, and then draped. All right, a cleaning solution, and then the syringe optional, and then the 1% lidocaine without adrenaline. Okay, and then the steps of procedure will be prepare the patient. Okay, position the patient, clean the area, insert the needles. Okay, LP needle with the bevel up, take out the stylet, and then the fluid will come. If the fluid doesn't come, then we have to rotate the needle in 90-degree. All right, and then reinsert the stylet. Okay, and then frequently check whether the fluid is coming or not. Okay, and if not, then reposition the patient with the properly flex, and then we have to make sure for another repunctures area. All right, now after the procedure is done, we have to send the CSF fluid for analysis. Okay, in the 4 bottle, 1, 2, 3, and 4. Okay, so now what are the complication of lumbar puncture? Okay, post LP headache, this is very common. Okay, so most of the patient will complain for this LP headache after the procedure. So it usually begins 24 to 48 hours after the procedures. Okay, the causes is because of the leakage of your CSF. Okay, and the kind of headache will be either like it's like a bilateral pressure or throbbing. Okay, that will be intensified if we keep the position, if we keep the patient in upright position. Okay, so and then of course the second complication will be back pain. Okay, occasionally this is like short life. Okay, the disc herniation if the needle advanced too far. Okay, if your needle is advanced too far beyond your subarachnoid hemorrhage, then there is a high chance of disc herniation. Okay, maybe because of this the patient might have this post LP back pain. All right, now coming to the next complication. Okay, infection to the CSF. Okay, it can occur. Okay, when we break in the sterile, um, when we broke the chain of the sterile technique, there is high chance of getting infection. Use of any contaminated equipment or any placement of the needle to the infected skin. All right, so the patient might have cellulitis, skin abscess, or epidural abscesses, or any spinal abscesses. The next complication is hemorrhage. Okay, if the patient have low platelet count or any if the patient have any coagulopathies, then there is high chance of bleeding. There is aesthesia or impairment of sensation. Okay, if you unfortunately hit any of the spinal cord, then is high chance of this aesthesia. Then post-dural punctured cerebral herniation. Okay, so this is very real. Okay, after this post LP, there is high chance of cerebral herniation where your brain tissue will be swelling, and then there is high chance of brain tissue moving from the original position to the other position because of this swelling. So there is a high chance of cerebral herniation, but this is very rare. Okay, there is 0 to 5%. And again, the next headache is spinal headache. So most common complication. Okay, the risk factors, it especially happen to female with the age of between 18 to 31 who have lower BMI, that is body mass index, who have the history of headache, and who have the prior spinal headache. Okay, so those patients who are female between 18 to 30 with a lower BMI, with a history of a headache, and with a prior spinal headache, so they had a high chance of getting this spinal headache, which is a kind of complication after your lumbar puncture. Okay, so it will improve. Okay, it will improve when we keep the patient in supine position. Okay, not in the upright position. Okay, we should keep the patient in supine position, not in the upright position, so it can last from hours to the week. Okay, so how do we treat it? Okay, keep the position in keep the patient in supine position for at least 2 hours, hydrate the patient. Okay, we can avoid this. Okay, bypassing this bevel parallel to the longitudinal fibers of dura, or we have to use a small diameter needles or using ultramatic needles. Okay, so these are a treatment. Okay, how do we prevent, not treatment, how do we prevent this spinal headache after LP? So now coming to the nerve root trauma or irritation. Okay, this is also another complication. Okay, we feel like electric shock or diesthesia. So after the procedure, so the patient will have this back pain which can persist for more. Okay, in case if the patient have this disc herniation, but this is very rarely permanent. Okay, this is just temporary. So for this, in order to prevent this nerve root trauma, we have to withdraw the needle immediately. Okay, after putting the stylet, after putting the stylet, we have to withdraw the needle immediately. Okay, if there is any pain or motor weakness persist, then we can start with the corticosteroid, and if then we can go for this electromyogram or nerve conduction NCB. Okay, nerve conduction velocity should be studied if the pain passes for longer periods of time. Okay, did you understand till now?
Yes, ma'am.
Now, so we have till now so far we have studied about the definition of LP, okay, spinal tap, the indication, the contraindication, the equipment required, and then the patient preparation. In patient preparation, we have two patient position: lateral decubitus position and sitting up position. And coming to the steps of procedures, after the procedure is done, now we have now we are dealing about complication, okay. That is your spinal headache, okay, and then nerve root trauma irritation, and then the next complication is herniation, okay. It is manifest initially as altered mental status, which will followed by cranial nerve abnormalities and casing triads, okay. It is very like rapidly fatal. So if we have to immediately remove, in order to not prevent this herniation, we have to remove the needle immediately and raise the head of the bed to 30-degree, okay, to improve venous return from the brain, okay. We have to give either mannitol or 3% saline, and in case if the patient have hyperventilation, we can intubate and we can consult a neurosurgical, all right, in case if the patient have herniation. Now let's come to the summary, okay. So now what is spinal tap, like just like let us know whether you have understood or not. So what is the position of the patient for the LP? Any one of you?
Lateral decubitus position and sitting position.
Yeah, so which one is the first choice for LP?
Between L3 and
Okay,
The competent position.
Lateral decubitus
okay.
position.
So we have to make sure that we do not puncture on the level of L1 and L2, because at the position of L1 and L2 vertebrae, your spinal cords end. So we should puncture below your spinal cord, okay, that is below your L1 and L2. So the position, so the area, the location will be in between L3, L4 or L4 and L5, that is after your spina cauda, okay. So now I think this is not a new procedure to all of you. So we have to write this procedure in your procedure book also. So please note this down in your procedure book also. By the time when we meet up in college, we'll do this signing and all this thing. So by the way, did you understand about this procedure? Like any question, any queries from your side?
We understand, ma'am.
Okay. So now the CR, I think, who is the CR now from your group? So please
Me and
send
Navanita.
me the length of the list of student absentees, okay? Only the student absentees. Now your ma'am Monica wants to talk with your CR. So CR, please call ma'am Monica once. Okay, then if you don't have any query, let's end this class, okay? Send me the list of absentee student. Okay, then bye all of you. Take care.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.